Hi, this is Nursing, and you're watching Endocrine Emergencies for Paramedics, part of our Pediatric Summer Lecture Series. The endocrine system works really tightly with the neurologic system and the cardiovascular system to promote normal metabolism, growth, development, blood glucose control, and sexual functioning. The majority of the endocrine system functions on what's called a negative feedback system, and this is a system of checks and balances that monitors levels throughout the body and adjusts as needed. This negative feedback system then helps maintain normal hormone balance and homeostasis. An example of a negative feedback loop is the insulin-glucagon feedback. So we'll start down here with the homeostasis circle. So we start with a normal blood glucose level, 70 to 100. And then after a meal, our blood sugar levels rise and our blood glucose is elevated. The beta cells and the islets of Langerhans and the pancreas release insulin into the bloodstream. Insulin has two functions. Then it can put glucose into the cell, or it can convert any extra glucose into glycogen and store it in the liver and the muscle tissues of the body. When the serum levels of glucose drop, that decreases the stimulus to release insulin, and if it drops too low, it would then stimulate the release of glucagon to break down the glycogen that's stored in the liver and elevate the blood glucose levels. Another good example of this is the thyroid, and pretty much most of our endocrine system functions this way. The glands that are included in the endocrine system include the hypothalamus, the pituitary, which is also referred to as the hypophysis, the adrenal glands, the thyroid gland, the parathyroids, the gonads, and the pancreas and those islet cells within the pancreas. There are two types of glands. There are glands that are exocrine and glands that are endocrine. So exocrine glands secrete via ducts outside of the body. So these are our tear ducts, our salivary glands, our sweat glands, and digestion. So those enzymes that are released into the digestive tract. The endocrine system then deals with the glands that secrete into the bloodstream itself and then are circulated to target tissues and organs within the body. So hormones are the chemicals that are secreted by these different glands, and these are chemical messengers that really only act on target tissues to create a physiologic response. Examples of these are things like, again, your thyroid stimulating hormone, which then increases the release of T4, which then is converted to T3. Calcitonin and your parathyroid hormones manage your serum calcium levels. You have glucocorticoids like cortisol and mineral corticoids like aldosterone that are released from the adrenal cortex, and then the adrenal medulla releases our epinephrine and norepinephrine. The kidney is responsible for calcitriol as well as renin and erythropoietin. So all of these have very specific functions in the body. Again, most of them function on a as needed basis with that negative feedback loop, but they only create a response in those target organs and tissues. So probably the most common endocrine emergency that we are going to deal with is going to be related to patients who have diabetes. And there are different types of diabetes. So diabetes mellitus is a problem with glucose regulation. Diabetes insipidus is a problem with antidiuretic hormone regulation. But both of them cause excessive urine output. So we're going to talk today about diabetes mellitus, type 1 and type 2. So the problem with diabetes, regardless of the type that you have, whether you have type 1, type 2, or gestational diabetes, is that you have a difficult time managing your glucose levels. And very specifically, you are prone to hyperglycemia. When your blood sugar levels elevate, that increases the viscosity or the thickness of your blood, and your body senses that increased blood viscosity and says, wow, I must be dehydrated. I should drink. And so we get a lot of thirst. When you have a high serum glucose level, that acts as a draw for water. So it has a lot of oncotic pulling pressure. And so it's going to draw interstitial and intracellular fluid to shift towards those intravascular spaces. And now, not only do I have thick blood, but I have too much volume. And so when I have a lot of blood volume, my heart sends out a hormone. So that's like ANP or BNP. So our brain natriuretic peptide, and it tells the kidneys to release more water. So basically it just says like, hey, my preload levels are too high. You need to make more urine. So we end up with polyuria. And interestingly, when we have a serum glucose of 220 or higher, we have what's called glycosuria, or glucose spilling into the urine. For the pregnant patient, that threshold is a little bit lower, so they might start spilling glucose in the high 100s. And at the same time that I'm having this struggle of not enough fluid, too much fluid, not enough fluid, too much fluid, my cells still aren't getting fed because I don't have adequate insulin to move available glucose into the cells. And so those cells then are sending out these chemical messages saying, hey, we're starving. And the brain says you should eat. And then, of course, this is this catch-22, because the more you eat, the higher your serum glucose is. And the higher your serum glucose is, the thirstier you are. And the thirstier you are, the more blood volume you have, and you start urinating more. So we talk about the 3 P's of diabetes, which are polyuria, polydipsia, and polyphagia. So urinating, excessive urination, excessive thirst, and excessive hunger. In patients who have type 1 diabetes or don't have any insulin production at all, they will develop ketone bodies, like serum ketones, so in the bloodstream, as well as Kussmaul's respirations. And I have posted a link for those of you who are attending the Vermont Tech Paramedic class in our Canvas of a phenomenal video made by a doctor of a child who has Kussmaul's respirations. Kussmaul's respirations, by definition, needs to be at least 18 breaths per minute, and they're this kind of deep sighing respiration, and you can see it very clearly illustrated in that video. So all of this, the polyuria, the polydipsia, the polyphagia, leads to hemoconcentration, which means that I have a lot of stuff in relation to the amount of circulating plasma. So I have, a lot of glucose and cells and proteins and electrolytes, rather than a lot of plasma. I end up with hypovolemia and hyperviscosity. So overall, I don't have an adequate circulating volume, but what I do have is super thick. And this then causes hypoperfusion and cellular hypoxia. Type 1 diabetes, when you develop diabetic ketoacidosis, so a glucose greater than 250, also has the side effect of metabolic acidosis secondary to cellular hypoxia. And that can actually be fairly significant acidosis. So if you remember the acid-base balance, your normal pH is 7.35 to 7.45, and lower than 7.35 is considered acidosis. Patients with significant acidosis from diabetic ketoacidosis can be down into like the 7.2s, like 7.27 or lower. To contrast that, somebody who has type 2 diabetes and always has a little bit of insulin typically doesn't have ketone bodies in their bloodstream, but they can still have ketones in their urine from just like dehydration. And they don't develop Kussmaul's respirations, but they do develop usually just a very mild acidosis if they are acidotic. Potassium can be normal, high, or low, and potassium shifts can occur with GI losses, so if there's any vomiting or diarrhea, with poor intake, but also potassium can be shifted in and out of the cell relative to the amount of hydrogen. So one of the things that we do see is hyperkalemia, so high potassium levels in the blood, as a direct result of an elevation of hydrogen ions or this metabolic acidosis. And so when I have a lot of hydrogen ions in the body, those actually can get into the cells. And when the hydrogen ions are taking up space inside the cells, so these are like kind of protein buffers and cellular buffers in the bloodstream, then potassium doesn't have as much space to occupy inside the cell and it gets pushed out of the cell. So when we're taking care of somebody who has hyperglycemia and we're correcting their diabetic ketoacidosis and their, with their hyperkalemia, when we give insulin for something like this, insulin actually not only attaches to glucose to move it into the cell, but it transports potassium back in with it. And so as we get more towards a normal glucose level, when somebody's recovering from hyperglycemia, oftentimes their potassium levels will actually dip low, and then we have to start replacing potassium. So hyperkalemia does not cause acidosis and is not caused by acidosis, but is kind of like a side effect of hiding hydrogen ions inside cells where potassium normally hangs out. So we'll start with type 1 diabetes, or diabetes mellitus type 1, which is also referred to as juvenile onset. The majority of pediatric patients that we take care of who have diabetes will have type 1 or insulin-dependent diabetes. So you can get this, obviously, if you have your pancreas removed, but usually as an autoimmune process. And so typically we see this in children after a viral infection where their immune system has kicked in, now recognizes protein tags on the beta cells of the pancreas, and it attacks them. And so no insulin is made. And this is a really critical distinction because zero insulin versus not enough insulin is really what distinguishes between the development of something like DKA versus HHS. These cells then cannot utilize any glucose because they have no way to get it into the cell, and the body then will start to burn fats and proteins for energy, and these are those ketone bodies then that are circulating in the bloodstream, so serum ketones, because the brain can use ketones as energy to function. A patient with type 1 diabetes typically is underweight. So they will experience weight loss because their cells are starving and their body is burning proteins and fats. Again, polyuria, polyphagia, polydipsia, and this leads to diabetic ketoacidosis if untreated. The most common signs and symptoms at onset, so if we have a pediatric patient complaining of these, we would obviously want to check a sugar, would be abdominal pain, thirst and dehydration, fatigue, flu-like signs and symptoms, and then the polyuria, polyphagia, polydipsia. So these patients can only take insulin. Oral medications will never work for somebody who has type 1 diabetes. But the other distinction is that patients with type 1 diabetes can eat and drink anything as long as they cover it with their insulin. So essentially, whether they have an insulin pump or an insulin pen, or they're drying up and giving themselves shots, and whether they have a consistent amount or sliding scale really varies by patient to patient. But they need to just supply the body with the insulin that the pancreas would have given them based on what they're eating. They should eat more and use the appropriate coverage prior to exercise because they'll utilize more glucose during activity. And that's also really important, is that just like any other child, if they don't eat enough and they exercise, they can, feel poorly. And in this case, they'll get hypoglycemic and have what we refer to as like insulin shock, where there's not enough glucose. We want to monitor really carefully for hypoglycemia, which looks just like other types of shock: pale, cool, clammy skin, confusion, tachycardia. Usually the distinguishing difference is obviously this history of diabetes and using insulin, but also that they feel hungry. If the person is awake and they have an intact gag reflex, they can protect their airway and they can swallow, then you want to give oral glucose. And if they are not, then you want to give glucagon and or IV glucose if we don't trust them to protect their airway. So the three kind of hallmark things that we use to manage a patient with type 1 diabetes are diet, exercise, and insulin. Insulin is, again, lifelong. There are different types of insulin. So something like Lantus is called a basal insulin. It's usually dosed once a day at night, and it lasts about 24 hours. There's sliding scale insulins that are given based on how many carbohydrates the person consumes with a meal or a snack. And then there's, regular insulin and fast-acting insulins, and there's an insulin pump that you can use where you don't have to give yourself shots. There's glucose monitoring that you can do with finger sticks or different subcutaneous sticks like on the arms. And then there's actual wearable glucose monitors. And we've gotten so advanced now that we have glucose monitors that will talk to your smartphone and talk to your pump and will make adjustments as needed up or down on your insulin based on your current glucose levels. It's a pretty amazing technology that's out there. And essentially at that point in time, that's just a wearable pancreas. Like, the technology is doing it all for you, and regardless of what you eat or how much you exercise, the pump and the monitor are going to talk to each other. Most of the monitors, though, you scan to your cell phone or your smart device, and then you adjust to your pump as needed. Follow-up is probably one of the most critical things. So it's really important that patients who have diabetes, especially, children from a young age, get close monitoring of their eye health, kidney health, feet and skin, and monitoring their hemoglobin A1C to make sure that they have tight control of their diabetes. So diabetic ketoacidosis, or DKA, is typically seen in patients who have type 1 diabetes when your glucose level exceeds 250 milligrams per deciliter. So we're using American units. We see ketonuria, so ketones in the urine from dehydration, as well as serum ketones from muscle and fat breakdown. The patient will have metabolic acidosis with respiratory compensation, which is those Kussmaul's respirations, and we see a positive anion gap. They also have an upset of fluid and electrolytes, so oftentimes sodium and potassium, and obviously their glucose, can be out of whack, and they're significantly dehydrated. Treatment is insulin and watching potassium, and since we don't do that in the field, for us, treatment is fluids, and more fluids. So common signs and symptoms of DKA, so again, polydipsia, polyuria, polyphagia, altered mental status like lethargy or stupor, changes in vision, acetone or ketone fruity breath smell, Kussmaul's respirations, nausea, vomiting, belly pain, and then spilling glucose into their urine. Patients with type 1 diabetes are also more at risk for experiencing hypoglycemia from either not eating enough, taking too much insulin, or exercising without adequate backup glucose in stores. So anytime the glucose gets less than 65 or 60, depending on their own threshold, then they will go into what we refer to as insulin shock, but basically it's hypoglycemia. So we have lack of adequate brain cell perfusion with glucose because there's not enough to go around. We don't have insulin to put it into the cell, or we have lots of insulin and just not enough glucose in general. The patient will be anxious, restless, hungry, confused, pale, cool, clammy skin from sympathetic activation, tachycardia, tachypnic. And then things like slurred speech, seizures, coma, and death are possible with hypoglycemia. This oftentimes is mistaken for alcohol or substance intoxication. So again, give sugar by the safe route. So think about oral versus IV versus IM glucagon, depending on how low they are and what you can get into them. So type 2 diabetes or diabetes mellitus type 2 is also called insulin resistant or adult onset diabetes, but we are seeing insulin resistant diabetes in pediatric patients related to obesity. So this is still called diabetes because of the polyuria, but it's really not the same problem at all. Basically, when you have chronic hyperglycemia, the insulin resistance starts to occur, or the cells are just like, whoa, there's too many people knocking on my door, you can't come in, and it just kind of is no longer receptive to insulin trying to move glucose into the cells. You can think of it this way: if you think of insulin as like a lock and key mechanism with a cell membrane, that in type 1 diabetes, they've just completely lost the key. So they can't unlock anything. And with type 2 diabetes, I have the key, I have insulin, but my locks are rusty. And so type 2 diabetes can be managed with oral agents as well as different injections and insulin, depending on what the person needs, but sometimes it can be modified with diet and exercise to get it back into a controllable level. There are modifiable and non-modifiable risk factors associated with insulin-resistant diabetes or type 2 diabetes. So my modifiable risk factors are all really about lifestyle. Getting your weight into a normal BMI range, having an active, healthy lifestyle, managing your cholesterol, so elevating your good cholesterol, which is the HDL, and lowering your triglycerides is really important. And then there's the development of what's called metabolic syndrome. So this is abdominal obesity with hypertension, an elevated fasting glucose, and even like an elevated hemoglobin A1C, but not quite at the level of diabetes yet. So this is kind of considered like pre-diabetic. Decreased HDL, which is your good insulin, and increased triglycerides, good cholesterol and bad cholesterol, increased triglycerides, which is bad cholesterol. I'm stumbling over that word today. That's the kind of the picture of metabolic syndrome, and that's one of the risk factors of developing heart disease, stroke, and type 2 diabetes. Non-modifiable risk factors then are things in your history that you can't change. So a family history of type 2 diabetes or obesity, your ethnicity, so Black and Hispanic are higher risk than Caucasian. Gestational diabetes with macrosomia, so large baby. Hypertension, polycystic ovarian syndrome, a hemoglobin A1C greater than or equal to 5.7, and a history of cardiovascular disease. So those are things that you're not going to be able to reverse because they've already happened. So when we develop type 1 diabetes, it's usually pretty fast onset after a viral illness, again, autoimmune. With type 2 diabetes, it is a slow onset, months to years, and when the glucose levels get significantly high, we start to develop the polyuria, polyphagia, polydipsia. Fatigue and poor wound healing are common, as well as the development of heart and kidney disease, visual changes, and recurring yeast infections, and those could be oral, genital, or in the skin folds. Treatment is focused on modifying the risk factors that you can control, managing blood glucose, and minimizing long-term complications. So the hyperglycemic issue that we run into with patients who have type 2 diabetes is usually called HHS, hyperosmolar hyperglycemic non-ketotic acidosis. And the non-ketotic means that they don't have serum ketones, but they might have urine ketones, and that's okay. So since the patient with type 2 diabetes makes some insulin, the body doesn't go into DKA. Instead, they experience profound hyperglycemia, usually symptomatic over 600, but they can easily be over 1,000 milligrams per deciliter. Serum osmolality, so this is how thick your blood viscous, like how thick your blood is, of 320 milliosmoles per kilogram or greater. So that means they're just super dehydrated. And they say that like with DKA, you need about 7 liters of fluid to have normal viscosity. And with HHS, you need like at least 10. So it's like super dehydrated. Serum pH is greater than 7.3. So they may have mild acidosis, but they're not going to be down into the 7.2s, which is what we see with DKA. Bicarb is greater than 15, so we don't have like these massive metabolic compensation. And then small ketonuria with absent to low ketonemia. So I can have ketones in my urine from dehydration, but I don't get those serum ketones that occur from starvation and fat and protein metabolism. And then altered mental status is also common. So whether you have DKA or HHS, you're going to be admitted to the hospital. The management of DKA, as I said, is insulin and then fluids. The management for HHS is fluids, 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 more fluids, and some insulin. So one of the reasons why obviously we want to correct this and keep a really tight control on this is because there are chronic effects of hyperglycemia. So whether you have type 1 or type 2 diabetes, the changes in blood viscosity impact your overall immunity. So it increases the risk of pneumonia, urinary tract infections, skin breakdown and infections that can cause sepsis, vascular disease, skin ulcers, retinopathy and vision loss, nephropathy and kidney failure, and peripheral neuropathy, which then leads to skin injuries as well as falls and trauma. There's also an increased risk of heart disease and stroke with hyperglycemia. So it's really important to us that we manage these glucose levels as tightly as possible. So let's step away now from diabetes and let's talk about some other endocrine disorders. Pediatric hypothyroidism can be infantile or juvenile onset. Remember that your thyroid is responsible for all of the kind of energy production in your body, and your thyroid, for lack of a better term, feeds your brain. So when we have hypothyroidism, we have developmental delays, and we have basically like a loss of energy to build and grow the body the way that we normally should. So this is an infant with hypothyroidism, and you can see these very classic signs and symptoms. So they have this kind of round abdomen because they have loss of muscle tone of the abdominal wall. That allows then for a large protruding umbilical hernia, a large thrusting tongue. So the tongue just looks really huge, and it tends to be kind of hanging out of the mouth. Loss of overall muscle tone, and then delayed development. So it's important that we recognize hypothyroidism in pediatric patients as soon as possible, because they're going to be on lifelong replacement, which is like levothyroxine or Synthroid. And you can never come off of it, right? But this is going to then help them hit their normal milestones, help them with normal cognitive function, and help them hit their growth charts. Congenital adrenal hyperplasia occurs basically when there's excess stimulating hormone, and the enzymes are missing that produce cortisol and aldosterone due to just a congenital defect. So they're built the wrong way. And this results in basically a pediatric form of acute adrenal insufficiency. So because the body can't produce cortisol, which is your glucocorticoid or like your sugar steroid, and they can't produce aldosterone, which is your mineral corticoid or like your salt hormone. We have both a loss of glucose, but then also sodium and water. So this is essentially acute adrenal insufficiency from a a problem of enzyme regulation. So what that looks like in a kid is, and again, infants, vomiting, poor feeding, and hypoglycemia, failure to thrive, so they're not growing. They're listless, and they get severely dehydrated. So treatment is lifelong corticosteroid replacement. And then for acute episodes, they'll need stress doses of steroids, just like the person who has Addison's disease or acute adrenal insufficiency. Some patients who have like too much salt loss with this also will go on a Florinef, which is a replacement for aldosterone. That's a mineral corticoid. The anterior pituitary gland controls the release of all of these stimulating hormones, right? So thyroid stimulating hormone and adrenocorticotropic stimulating hormone, and stimulation for growth hormones and stimulation for sex hormones. And so when we have a problem with the pituitary gland, so if we have a lack of pituitary stimulation or output, we end up with hypothyroidism and acute adrenal insufficiency and lack of sympathetic stimulation and poor growth and lack of sexual maturation or development of secondary sex characteristics. So it's critical. The ones that we would replace first would be thyroid and cortisol, and then we would kind of go from there. So this is called panhypopituitarism, when we have hypopituitary and everything is kind of too low. So when we're looking at hypopituitary or panhypopituitarism, we have hypoglycemia, hypotension, hypothermia, hyponatremia, hyperkalemia, because aldosterone typically holds on to salt and water and releases potassium, but when we are lacking aldosterone, we end up holding on to too much potassium. And then we have loss of bone and muscle mass, loss of menses, loss of ovulation, loss of reproductive abilities, hair loss, weight gain, and decreased libido. So most of this is directly related to problems with the thyroid and the adrenal hormones. So we would want to replace those. Conversely, if we had hyperpituitarism, so if we had too much pituitary output, we would have elevated glucose levels, hypertension, hyperthermia, hypernatremia, hypokalemia, exophthalmos, which are the bulging eyes that you see with hyperthyroidism and Graves' disease, weight loss, increased bone densities, coarse facial features that you see with acromegaly, which is too much growth hormone, and irregular menses. So once we get these under control, and like with the panhypopituitarism, once we replace those hormones, children usually grow and mature normally as they would. And lastly, in this section is inborn errors of metabolism, or IEMs. So, basically some children are born with the inability to metabolize substances like macronutrients, their fats, their proteins, their carbohydrates, and then certain amino acids within the body. These oftentimes are genetic, so there's a family history of the same, or there's a like an ethnic risk factor for developing these. These are, because they can be fatal and cause cognitive impairment like brain damage, these are the ones that we screen for prior to discharge from the hospital with pediatric heel sticks. Management is usually with dietary restrictions, so avoiding the things that they can't eat or taking special supplementation so they can digest and break things down. So some examples are maple syrup urine disease, and interestingly, those kids smell like maple syrup, fetal ketonuria or PKU. And this one is pretty interesting because they can't break down phenylalanine, which is an amino acid that's present like in all proteins, and so they can't even breastfeed. And because their PKU levels don't rise until feeding has been established, typically PKU levels aren't elevated until 4 to 5 days out from birth, but we test them at 24 hours before they get discharged. So this is one of the reasons why that follow-up care at the hospital is so important, is because they usually have them come back at 4 to 5 days later and get tested again, just to make sure. There are like low phenolac, there are certain formulas that are low in phenylalanine that they can eat, and people who have PKU are allergic to aspartame, the phenylketonurics, right? So they can't have anything that has aspartame in it. Galactosemia is it's another one, so they can't break down basically like milk proteins. So just to give you an idea, these are the things we screen for, and then they get followed pretty closely. Again, you probably won't be called for these as a specific chief complaint, but if you have a patient who has an inborn error of metabolism, just know that the family is going to be the expert on the subject matter, and you should never feel embarrassed to say, I'm not really sure I know enough about this. Can you tell me, what I should be concerned about or what I should be watching for? And they're usually super happy to educate you and just kind of take you through, like, these are the things that could happen, or this is what you do in the case that this happens. So always utilize the family when you're taking care of a patient who has one of these congenital or genetic problems, because again, the family has probably done more research than anyone other than like the doctor who specializes in it that's taking care of them. All right, well, thank you for watching Endocrine Emergencies. As always, I hope you enjoyed this presentation, and I look forward to seeing you again.